Hello everybody and welcome to our presentation on testing approaches to implementation and understanding factors influencing success, complementing a cluster RCT with a process evaluation. My name is Natalie Taylor and my colleague April Morrow will be following on from this presentation, which is for the TIDIRH Australia May 2020 workshop. Okay. So just to give you an overview of what we'll present today, we'll give you a background to the cluster RCT testing two implementation approaches for changing healthcare delivery in the context of colorectal cancer and genetics. So that will include an overview of the trial design. We'll give you an introduction to process evaluation, an explanation of process evaluation methods used alongside the trial, and some insights to date. Just like to present a little caveat, which is that we assume prior knowledge of the theoretical domains framework and behaviour change techniques of the audience. This is just a quick overview of our team. So the wider team there at the top is the Cancer Research Division at the Cancer Council New South Wales, and the picture below is our project team. So we're the Behavioural and Implementation Research and Evaluation group. I lead that group and I'm the chief investigator of this study, and we also have our project team listed below, including April Morrow, who is the project specialist and PhD student on this project. So why do we want to test theory and non-theory driven approaches to implementation? Theoretically underpinned implementation frameworks can optimise and contextualise the design of behaviour change interventions, as well as increase opportunities to understand generalisability to other settings. But to understand the impact of the use of theory in an implementation approach and to advance the science of behaviour change in healthcare, it's important to distinguish the theoretical components whilst holding as many of the other aspects of the implementation approach constant. The context. So in this study, we're talking about colorectal cancer and Lynch syndrome. Lynch syndrome is a hereditary cancer predisposition syndrome. Tumour-based screening allows the identification of patients at high risk of Lynch syndrome, and patients at high risk should be referred to specialist genetic services for germline testing to establish a diagnosis. Diagnosing Lynch syndrome allows access to risk management strategies effective in preventing cancers and improving survival, and can also allow for cascade testing among relatives. Lynch syndrome remains largely underdiagnosed and genetic referral rates are very poor. Some Australian studies suggest up to 70% of patients with an abnormal mismatch repair gene are not referred to genetics. So the Hide and Seek project, HASP, is a cluster RCT to assess the effectiveness of two different implementation approaches to improving Lynch syndrome referral amongst colorectal cancer patients. It targets the behaviours of healthcare professionals involved in the Lynch syndrome referral pathway, such as surgeons, pathologists and oncologists, and we've recruited 8 hospital networks across Australia. The theory or non-theory trial arms are distinguished only by the use of a theoretical framework, the theoretical domains framework, to identify barriers and design targeted intervention strategies, so behaviour change techniques. These implementation approaches are delivered by trained health professionals, which we will refer to as implementation leads, over a 2-year period employed at 0.2 FTE. Here's a list of the Hide and Seek project investigators and exactly where all of the hospitals are positioned in Australia. And this is an overview of the HASP trial design. So we have baseline audit data collection, which has been led by the implementation leads who have received training through a 1-day workshop and ongoing support. These implementation leads have also formed an implementation team, identified target behaviours for change using process mapping of the Lynch syndrome referral pathway to identify gaps and bottlenecks, And as we progress in the trial, they'll be using this information to identify barriers to specific target behaviours for change through surveys and focus groups, and then co-designing intervention strategies using information from those barriers and depending on the theory or non-theory trial based arm, using behaviour change techniques to design those intervention strategies. Following this, they'll work with their implementation teams to design and implement the interventions, and this will be followed by a post-intervention audit. The HASP study aims are to increase the proportion of colorectal cancer patients with risk-appropriate completion of the Lynch syndrome testing and referral pathway within 2 months of surgery, compare the effectiveness of a theory-based implementation approach against a non-theory-based approach for improving detection of Lynch syndrome amongst Australian colorectal cancer patients, and also to establish the most cost-effective implementation science approach for identifying Lynch syndrome patients. The trial outcomes for HASP will be the change in the proportion of patients with risk-appropriate completion of the site-specific Lynch syndrome tumour testing and referral pathway within 2 months of colorectal cancer resection. Secondary outcomes include the proportion of high-risk patients who are referred to the familial cancer clinics, which looks at sensitivity of referral, the proportion of referred patients who attended the familial cancer clinic, and those with missing testing and referral data. Evaluating the HASP trial. So whilst Lynch syndrome referral data are assessed pre and post implementation to determine clinical effectiveness will be done, interpreting HASP trial outcomes is very complex. Implementation interventions often have multiple components, require multiple people to change multiple behaviours, and are highly context dependent. Even in tightly controlled implementation trials, the same intervention can have very different outcomes from one hospital to another. And there is also the generalisability problem. Assessing Lynch syndrome referral rates is only one small piece of the puzzle. RCTs are important in establishing effectiveness, but focusing only on clinical outcomes means there is an inability to explain why an intervention was or was not successful. Even if interventions lead to improvements in Lynch syndrome referral rates, they may not translate successfully to other settings. So we further need to understand what works, why, in what context, and at what costs. And this can be answered via a carefully designed process evaluation. Process evaluations are exploratory studies that seek to complement outcome evaluations by understanding how an intervention works in practice. Aims of the HASP trial process evaluation are to evaluate the implementation of the HASP trial, identify potential mechanisms of impact, examine contextual moderators, and collect HASP cost data to inform an economic evaluation. So I'm going to lead into April's presentation now. So April is doing a PhD on the HASP trial through her process evaluation. I'll hand over to April.
Thank you, Natalie. So we'll be conducting a mixed methods process evaluation alongside the HASP trial that incorporates both qualitative and quantitative data. So our measures will include stakeholder interviews, audio analysis of meetings and focus groups, barrier questionnaires using the theoretical domains framework, fidelity checklists, project logs, and observations of multidisciplinary team meetings. And this diagram here shows the interdependencies between context, implementation, and mechanisms of impact and their influence on study outcomes, and how the above measures fit into each of those aspects. And so I'll go into a bit more detail on that in my next few slides, but the model itself has been adapted from the UK MRC guidance on process evaluations by Moore and colleagues, which is a really great source of information when thinking about how to design a process evaluation. And I've popped the reference below for you there. And I'll essentially be fleshing this model out for each site and their intervention strategies as I gather data along the way. So implementation refers to the structures, resources, and processes through which an intervention is delivered and also the quantity and quality of what is delivered. And it's important to evaluate implementation because when an intervention is unsuccessful, we need to figure out whether it's because it's inherently faulty in its concept or design, or whether it's just been poorly implemented. And so Proctor developed a framework of 8 implementation outcomes, which include factors like acceptability, feasibility, fidelity, and sustainability. And whilst I won't go into them all in detail, essentially I'll be using these to code interviews and other data sources to better understand what is delivered and how. And so once the site-specific interventions have been designed, I'll also be developing fidelity checklists that specifically assess whether it's been delivered as intended. So say, for example, if we were to design an intervention where colorectal surgeons were to complete a checklist to assess Lynch syndrome risk for each patient, but they're only filling it out for, say, 1/3 of their patients. And even when they do, it's not filled out properly or there's information missing. That's something that we'd be able to capture through that. So the next aspect is mechanisms of impact, which refers to the way intervention components and people's interactions with them trigger change. And so theoretical frameworks can be really helpful when looking to both design intervention strategies and identify mechanisms of impact. And the behaviour change techniques taxonomy, or the BCT, is particularly helpful because it describes a whole host of behaviour change techniques and specifies their underlying behaviour change mechanism. And so you can use this information to put together a quick model of how the behaviour change process might look for a given intervention, which I've done here for the HASP trial. And this is hypothetical because we're not quite up to that stage of the trial just yet. But a hypothetical example, which I've shown in this diagram, might be the TIDIRH barrier, memory and attention. So, for example, surgeons simply forgetting to refer their patients. The BCT you might then use to address that barrier might be something like prompts and cues. And then your resulting intervention strategy might be the addition of referral prompts on pathology reports or the use of proformas. So the next aspect that I'll be looking at is context, which refers to the external factors that influence the delivery and functioning of interventions. And so that can include things like the physical, organisational, interpersonal and legislative structures. And so assessing context is key to determining transferability and also informing the design and implementation of subsequent interventions. And so the Consolidated Framework for Implementation Research, or CIFA, that framework can be really helpful in capturing different elements of context. And I've included a diagram of the model here, or the framework here. And so I'll be referring to these constructs and domains in our qualitative analysis, which I'll show you a little bit later. Another important aspect to capture is costs. So even when the clinical and cost effectiveness of a clinical practice guideline is well established, those benefits have to be balanced against the resources that you need for effective implementation. However, we know that implementation studies often fail to incorporate cost data, and those that do tend to focus only on clinical intervention costs and fail to take into account implementation costs. So to address that, we've incorporated measures to document time and resource use, both by hospital staff and the research team at Cancer Council New South Wales. And we'll be doing that via detailed project logs. We'll then be feeding those costs into existing modelling platforms to determine the more cost-effective implementation approach, and also to project longer-term clinical and economic outcomes. And that's really important for both researchers and policymakers when justifying funding for future scale-up efforts. And so you might be starting to appreciate just some of the complexities of evaluating an implementation trial. But I guess the HASP trial is particularly unique in its design in that we've really got 3 tiers of evaluation. So the first tier is the implementation approach itself, so a theory versus a non-theory implementation approach. And then in the second tier, we've got the intervention strategies that have been developed. And we currently don't know what those interventions are at this stage of the trial, but there could be more than one for each hospital. And then we've got the relationship between 1 and 2. So for example, does a theory-informed approach lead to better intervention design? So in terms of where we're currently up to in the trial, most sites are now at the stage where we've process mapped the Lynch syndrome referral pathway and identified target behaviours for change. And we're about to start assessing barriers to change so that we can design targeted intervention strategies. And so even though we're still relatively early on in the study, there have already been some really interesting findings from the process evaluation so far, and I can share a few insights with you now. So we conducted post-training interviews of the implementation leads, and a few key themes emerged from those. The first was really valuable feedback on the training program itself and ways that we can improve. And the other aspect was that implementation leads really valued the ongoing support being provided by the research team, especially when they were applying new implementation skills or knowledge that was new to them. Some anticipated barriers and facilitators to implementation also emerged, the first being practical and logistical challenges. So for example, just being able to get a team of very busy health professionals together in the one room. Also things like hospital culture. So as you can see in the quote here, where one site has research really well embedded and staff are very open to change and improvement efforts. You've also got things like staff engagement and the impact of delays. So for some of our sites, there were significant delays in getting governance and ethics approvals, and also some administrative hurdles. And things like that can really impact a study's momentum and staff engagement as well. Another theme that emerged was related to hospital capacity for implementation. So participants felt that having someone employed and dedicated to the implementation lead role within a site was crucial, in that it meant that the workload was more manageable for other hospital staff and they were therefore more willing to be involved. And there was also a sense that the skills and knowledge gained from involvement in the trial would be transferable to other clinical problems and also build long-term capacity for improvement efforts in the future. And so this is a very busy slide, but really it's just to show you the complexity of some of the process maps that have been developed. And I've pulled out some quotes from the process mapping meetings that were audio recorded, just to highlight the many ways in which patients can fall through the Lynch syndrome referral cracks. So for example, in the top left corner, people getting lost in the whirlwind of diagnosis and chemo, things like confusing pathology reporting, and then you've also got patient level factors like age at diagnosis and family history. And then just the complexity of the referral pathway itself and the fact that there are so many points at which the process can fail. And you can see that from all of the steps in these process maps here. And so you can see that even very early on in the study, by analysing meeting transcripts, we can get some really valuable insights on referral barriers. And so we've also had a few significant challenges that have come up since the trial started, which highlights just the importance of capturing context and fidelity. And so I've provided a few examples here, which I've mapped to the CIFA domains, just to highlight how these frameworks can be helpful when we're thinking about contextual factors that might impact the success of an implementation trial. And so, for example, we've had issues with staff engagement, and that can be mapped to the domain of individuals involved. So for example, at one site, we had a pathology head of department who agreed to participate in the early study phases, but has since failed to engage despite multiple attempts. And that's unfortunately meant that we have been unable to implement any pathology-related interventions, despite that the process mapping exercise had indicated pathology as a key area to target in order to improve Lynch syndrome referral. We've also been navigating the COVID-19 situation, and this could probably be mapped to a number of the CIFA domains, but I've used the inner setting just as an example, particularly with the construct of implementation climate. So as you can imagine, the virus has had a huge impact on hospital working practices and elective surgeries. Staff are faced with competing priorities, and there's also this climate of fear and anxiety. We've also been unable to progress with study activities as we originally planned, given that we're unable to conduct meetings and focus groups in person. And also the fact that a lot of research activities have had to be put on hold, and how that impacts momentum and staff engagement. There's also been a new introduction of Medicare items to fund Lynch syndrome genetic testing. So previously, Lynch syndrome tests could only be ordered by genetic specialists, but the new items allow ordering of tests by non-genetic staff. So it's possible that with these new items, that colorectal surgeons or oncologists might begin ordering genetic tests without having to refer first to genetics. And so that's something that could potentially have a huge impact on the referral pathway and the work that's been done so far. And so you can see just from these three examples how context can have a huge impact on an implementation effort. And we've had to take a pragmatic approach to adapt to these situations as they arise, but it has meant making significant modifications to our study design and protocol. And so all of these changes are being captured in a deviations log that we've put together, and we'll also be exploring their impact in more depth via our qualitative interviews. In costing the study, we've also had to make some key decisions along the way. The first was related to research versus real world costs, because we know that there are expenses related to research and development that wouldn't necessarily apply if we were to translate this approach to a real world setting. So those expenses include things like training materials and resource development, and also the support that the research team is providing to ensure fidelity to the study protocol. And so we've made the decision to distinguish between research and real world costs so that we can factor that into our modelling projections. But that being said, it's not always a clear-cut distinction, and the lines between research and real world can be a bit blurry. We've also had to take into account the effects of learning. So for example, the tasks being performed by the research team may become more proceduralised and streamlined over time. So there can be significant time differences between the first and last site for any given task. And so to account for that, we've taken averages across sites, but we're also noting the kind of best case scenarios time-wise, so that, again, we can factor that into our modelling work. And so in summary, all of these different pieces of process evaluation data can be triangulated to create a detailed picture of the factors affecting implementation success. And this information can be used to inform the design of future interventions to improve Lynch syndrome detection on a much larger scale and also across different contexts, but also to address other clinical problems. And so by capturing all of this information, we're also contributing to implementation science efforts more broadly by improving understanding of the factors affecting implementation success. And so I thought I'd finish up with a few take-home messages. So hopefully you can appreciate that focusing only on clinical outcomes when evaluating a complex intervention is really not enough. And process evaluations are really important in facilitating upscaling and allowing lessons that we learn from these trials to be applied to other settings. And when conducting a process evaluation, theoretical and implementation science frameworks can be really helpful in guiding your analysis and the interpretation of your findings. And also don't be afraid to use more than one to suit your needs. Thank you.
Thank you very much for listening to our presentation. Thank you, April. And yeah, that's it.